Welcome back to Pathognomonic Immunology. This will be a relatively brief lecture covering some of the immunosuppressants you should be familiar with for your boards. A few words on immunosuppressants in general before we get into specific drugs and their mechanisms. Immunosuppressants are used in certain instances when we want to suppress the immune system. We would have an interest in doing this in certain inflammatory conditions and especially autoimmune disease. Many of the drugs used for autoimmune disease are antimetabolites, and so can also be used as antineoplastic agents. These will not be covered in this lecture. Most of the ones we will talk about can be used for acute transplant rejection prophylaxis by suppressing cellular immunity. It should be noted that all of these drugs are extremely potent and each has their specific toxicities that patients are at risk for when taking them chronically. But in general, since we are suppressing the immune system, they all come with the inherent risk of infection and a greater chance of developing cancer. But multiple immunosuppressive drugs can be combined to get better results without reaching the toxic level for an individual drug, and we do this to avoid some of the more specific side effects. Let's first discuss the main cell targets in immunosuppressive therapies, and then we'll discuss the pharmaceuticals we use to alter these pathways. Since transplant rejection is a type 4 hypersensitivity, most of the drugs given for immunosuppression in these patients target T cell proliferation and cytokine signaling. So this is a helper T cell with its T cell receptor, and this is the nucleus down here. NFAT is the nuclear factor of activated T cells. This is a transcription factor found in many immune cells and plays a role in the upregulation of many inflammatory cytokine genes, including IL-2. When the T cell receptor is stimulated by binding its antigen, this causes calcineurin, a phosphatase in cells, to activate NFAT by dephosphorylation. And we've already been introduced to NFAT's buddy, NF-kappa B, the nuclear factor of activated B cells. We talked about it when we discussed toll-like receptor signaling back in our innate immunity lecture. This transcription factor is ubiquitously expressed, is found in almost all cells, and has many different roles. For our purposes, think of it as having a similar role to NFAT in inflammatory gene regulation. The IL-2 receptor is a prime target for immune suppression. This is because, as we know, IL-2 is a growth factor cytokine with widespread effects on immune cell proliferation, so blocking the receptor means less immune cells. When the IL-2 receptor is stimulated, it activates mTOR. mTOR is a protein kinase with downstream effects on translation. Its pathway is central to metabolism and growth, and inappropriate activation of the mTOR pathway has been implicated in many malignancies. IL-2 is called aldesleukin in drug form, and it works by causing the proliferation of immune cells. One of its main uses clinically is to activate natural killer cells to kill tumor cells in renal cell carcinoma. First drug up is cyclosporine. These first few drugs we're going to mention must bind a protein in the cytoplasm. It won't be hard to remember that cyclosporine has an affinity for cyclophilin. Its mechanism of action is inhibiting calcineurin, and as we can see in our diagram, this will not allow NFAT to be activated, so less inflammatory cytokine transcription. And so cyclosporine inhibits IL-2 production at the transcription level. It's used in combination regimens for transplant rejection prophylaxis and also severe rheumatoid arthritis, psoriasis, and off-label for other autoimmune diseases. Let's discuss side effects. When it comes to studying side effects for the boards, here's some general advice. Pay closest attention to the effects that are the most common, most dangerous, and most unique to a certain drug. Adverse effects you should know for cyclosporine are that cyclosporine, and in fact all calcineurin inhibitors, are very nephrotoxic. For some reason, these drugs cause vasoconstriction in glomerulus arterioles and can lead to anything from a reversible rise in serum creatinine to progressive renal dysfunction. This is one of the most common effects and is the highest yield. Calcineurin inhibitors can also be neurotoxic and commonly lead to tremor, less commonly to more severe hypertension-induced seizure. Calcineurin inhibitors can cause metabolic issues like high triglycerides and insulin resistance, but these effects are not super high yield because most of the drugs we're going to discuss in this lecture cause problems with metabolism, so it's hard for them to test you on it. And these last two are not super common, but since they are specific to cyclosporine among the immunosuppressants, they are more testable. Gingival hyperplasia, or gum overgrowth, is thought to occur due to the effect of cyclosporine in increasing TGF-beta as part of its anti-inflammatory mechanism of action. TGF-beta, however, also plays a role in wound healing and is associated with fibroblast activation and connective tissue deposition, which manifests in the gums as hyperplasia. Cyclosporine can also cause hirsutism. This may not be physiologically accurate, but I think of cyclosporine as just causing a bunch of stuff to grow, as seen in the obliterative arteriolopathy in the glomerulus, overgrowing gums, and overgrowing hair. Once we get cyclosporine down, Tacrolimus is pretty easy. We'll just focus on the differences. The first difference is that it binds FK506 binding protein, not cyclophilin. This would be pretty easy to remember if you can recall that the other name for Tacrolimus is FK506. The mechanism of action is the same, and Tacrolimus also inhibits calcineurin. The adverse effects, therefore, are also mainly the same. They are just as nephrotoxic, they are neurotoxic, and cause metabolic syndrome. But if they're going to test this against cyclosporine, you'll have to know that Tacrolimus does not cause gingival hyperplasia or hirsutism. What about Cyril Imus? The molecule we've already introduced, mTOR, stands for mammalian target of rapamycin. Rapamycin was originally used as a macrolide antimicrobial, much like azithromycin, until its effects on the immune system were discovered. Now it goes by the name Cyril Imus. Just like the other limus, Cyril Imus binds FKBP in the cytoplasm, and the similarities stop there, which makes it a little bit confusing because although they sound alike, Tacrolimus actually has more in common with cyclosporine. If you know that Cyril Imus is rapamycin, it makes sense that it blocks the target of rapamycin, mTOR. And since we know that mTOR is a downstream effector of the IL-2 receptor and is necessary for the growth and proliferation of cells, its inhibition will not allow an immune response to develop. While calcineurin inhibitors are nephrotoxic, Cyril Imus is not, and therefore has a special utility in the setting of kidney transplant. It's also one of the drugs used in drug-eluting coronary stents. This is to prevent endothelial growth over the stent and decrease the risk of restenosis. However, patients getting this stent rather than a bare metal stent must be on dual antiplatelet therapy for a longer period of time, as the lack of re-endothelialization of damaged vessels raises the risk for thrombosis. Adverse effects that are associated with Cyril Imus include pancytopenia, which makes sense if you're inhibiting cell proliferation. And you can get insulin resistance and a rise in cholesterol with Cyril Imus as well, which we've said makes this point virtually untestable. But the main takeaway point here is that Cyril Imus is not nephrotoxic. There are a couple of low-yield monoclonal antibodies, basiliximab and daclizumab, that have very specific uses in immunosuppression. There's not that much to know about them. These drugs block the IL-2 receptor directly, which as we've now established will downregulate the immune system. Daclizumab blocks the CD25 portion of the receptor. We've mentioned when discussing Tregs in our cell-mediated immunity lecture that CD25 mutations are associated with multiple sclerosis, so blocking this receptor can be helpful in treatment. On the other end of the high-yield spectrum are the glucocorticoids. This is the highest yield class of immunosuppressants because they're so commonly used. There's a lot to talk about. Corticosteroids are made endogenously by the adrenal cortex and released under conditions of stress. They have many diverse physiologic effects on several organ systems, including regulation of metabolism, but we'll first focus on their immunomodulatory effects. Let's start by being able to identify these drugs by name. They'll all end in the suffix -one and have names like prednisone and methylprednisolone, which can be given IV or as a Medrol dose pack, dexamethasone, which is Decadron, hydrocortisone, etc. Steroids are hydrophobic and can cross the cell membrane, so glucocorticoid receptors are intracellular. Once bound to its receptor, the steroid is transported to the nucleus, where it interacts with DNA promoter regions and regulates the transcription of certain genes to exert its effects on the immune system. One known mechanism is that of inhibiting NF-kappa B, which we know is a transcription factor involving the production of pro-inflammatory cytokines such as IL-2, so there will be less of these made. They're therefore used to suppress the activation and proliferation of all lymphocytes, including T cells and B cells. Through multiple mechanisms, glucocorticoids reduce peripheral lymphocyte counts in minutes. Another major role of glucocorticoids in medicine is as an anti-inflammatory. These effects are due to their inhibition of phospholipase A2, which shuts down the arachidonic acid pathway and the production of inflammatory mediators like prostaglandins and leukotrienes. So let's read this in the text. Glucocorticoids decrease cytokine production at the genetic level, leading to an overall suppressed immune response. They also cause T-cell apoptosis by some complex mechanism. And they can be used as anti-inflammatories as well because they disrupt the arachidonic acid pathway by inhibiting phospholipase A2. Their uses are too many to enumerate here, but very broadly, glucocorticoids are especially useful in reducing the number of circulating helper T cells so they cannot get to sites of antigen stimulation. This makes steroids good immunomodulatory agents to prevent transplant rejection. The fact that they also inhibit immunoglobulin synthesis means that they are often used to treat flares in autoimmune disease, and they can be used as anti-inflammatories in just about any inflammatory state. Many leukocyte counts will go down in response to steroids, including eosinophils, and so they can be used locally as topical agents to treat allergic dermatologic conditions, as well as directly inhaled into the lungs to treat more persistent cases of asthma. Here we have a whole slide dedicated to the side effects associated with exogenous steroid administration. These are potent drugs that come with a lot of morbidity. This is why we don't want patients on systemic corticosteroids for prolonged periods of time, and we try to get them off when we can. The first side effect we'll discuss is not really that big a deal, but since it's so common, it's important to know that it's no big deal. This is the fact that with steroids, patients will get an artificial transient neutrophilia. NF-kappa B has a role in the production of neutrophil adhesion molecules, which facilitate neutrophil migration out of the vasculature. Glucocorticoids prevent this by causing the demargination of neutrophils from their attachments to the vessel wall, which contributes to their anti-inflammatory properties. However, the circulating neutrophil count will go up. Examiners like you to know that if you see this acute rise in white count on a CBC after giving steroids, it does not necessarily mean you should go looking for a bacterial infection. That being said, steroids do increase the risk of infection because of this inhibition of neutrophil migration, and because they suppress the production of IL-2, be on the lookout for reactivation of latent infections such as TB or candidiasis. Patients on chronic steroids can even get some opportunistic infections like PCP because of decreased T-cell counts, and asthmatics inhaling steroids can get oral thrush if they don't use a spacer. As we've alluded to, glucocorticoids also exert many metabolic effects. For one, they antagonize the peripheral effects of insulin, the main anabolic hormone of the body. It's high yield to know that this insulin resistance causes hyperglycemia, and diabetics getting steroids may have higher insulin requirements. Remember too that cortisol is a stress hormone. Under conditions of stress, it's important for more glucose to be around for brain function. Glucocorticoids modify gene transcription to allow for important gluconeogenic enzymes to be made in the liver, contributing to the hyperglycemia. Besides increasing the output of glucose from the liver, they also increase liver storage of glucose in the form of glycogen by increasing production of the enzyme glycogen synthase. This glycogen reserve is important in times of stress as well. In order to provide the substrates for gluconeogenesis, there must be catabolism of protein and diversion of amino acids to glucose production in the peripheral tissues. Keep in mind that the anabolic effects of insulin are being blocked and not working so well. Thus, steroids have a proteolytic effect on skeletal muscle. This causes muscle atrophy and proximal muscle weakness. These same mechanisms promote lipolysis at adipose tissue. Fat tends to be redistributed in these patients centrally from the extremities to the trunk, leading to central adiposity, and the protein breakdown and myopathy contribute to patients having disproportionately thin extremities. In the face, fat deposition causes rounding and is a reason for the classically described moon facies, which you can see in this image, and redistribution to the upper back and nape of the neck results in the so-called buffalo hump, which is probably not the nicest of terms. Glucocorticoids also inhibit fibroblast proliferation and collagen formation, making the skin very susceptible to damage from even minor trauma. There is skin thinning, and purple striae are a classic manifestation of this, which can also be seen in this same patient. Patients even on topical steroids are easily bruised because the connective tissue in capillaries is thinned as well. Another manifestation of inhibiting fibroblasts is that wounds will not heal so easily, causing ulceration, and further increasing the risk of infection. And by inhibiting prostaglandin synthesis, glucocorticoids can cause GI peptic ulcers the same way NSAIDs do. Glucocorticoids also decrease bone mass by several mechanisms, one of which is inhibiting bone formation by osteoblasts. This causes osteoporosis and easy fracture. And because of this imbalance of bony resorption, chronic glucocorticoid use can also cause osteonecrosis and is one cause of aseptic necrosis of the femoral head. This is a normal x-ray of the hip, and you can see the head of the femur has a nice smooth contour that mirrors the shape of the acetabulum. With necrosis, the femoral head becomes jagged and irregular. A few other side effects to mention. Certain steroids can have some mineralocorticoid effects in addition to their glucocorticoid effect. This will look like hyperaldosteronism, which will lead to sodium and fluid retention causing hypertension, along with increased potassium excretion and hypokalemia. Steroids can also cause increases in intraocular pressure from decreased aqueous humor outflow in the eye, leading to open-angle glaucoma, and they can potentially cause cataracts due to a mechanism that may have to do with decreased lens protection from oxidative stress. High corticosteroid levels also repress GnRH secretion in the hypothalamus, decrease production of follicle-stimulating hormone and luteinizing hormone, and a secondary amenorrhea. High doses of steroids can sometimes lead to a corticosteroid-induced psychosis, which usually manifests as confusion or even hallucinations that resolve when the steroid is discontinued. Patients taking steroids chronically also very frequently experience insomnia. The last effect of chronic steroid use is also the most serious because it can be deadly. We mentioned that there are several metabolic effects that cortisol has in times of stress, but there are effects on circulation as well. Cortisol raises blood pressure by upregulating alpha-1 receptors on arterioles, thereby increasing their sensitivity to epinephrine. This helps maintain vascular tone. In patients with primary adrenal insufficiency, such as Addison's disease, where cortisol is not being made, even minor traumatic or infectious stimuli increase the body's stress response. Without cortisol present to maintain homeostasis, the effect may well be acute hypoglycemia, shock, and possibly death. Exogenous glucocorticoids can save these patients. On the flip side, though, chronic exogenous steroid administration has a negative feedback effect on the pituitary, saying we got enough cortisol and we don't need any more. The pituitary will stop producing ACTH, which means no stimulation of the adrenal cortex, causing adrenal cortical atrophy. This is a secondary adrenal insufficiency, and these patients are getting all of their glucocorticoids from the pill bottle. If they abruptly stop taking them, or if there's a sudden increase in stress, such as a trauma that requires a higher dose, these patients can experience acute adrenal crisis. This is super important to keep in mind when a patient chronically on steroids is undergoing surgery. They are not making enough cortisol to deal with that extra stress, so you must give them stress dose steroids and bump it up a bit. If many of these other manifestations seem familiar, it's because we're basically describing the clinical picture of an iatrogenic Cushing syndrome. Cushing syndrome occurs because for whatever reason the body has too much cortisol, which causes many of the catabolic effects we've mentioned. There's a cool mnemonic I found for the symptoms of corticosteroid excess, which I've modified a bit, and the mnemonic is BAM, Cushingoid, which is a descriptive term for people with the classic outward appearance of Cushing syndrome. B is for buffalo hump, which represents fat redistribution. A for amenorrhea, and M for muscle wasting. C is for cortical atrophy and crisis. U for ulcers, representing poor wound healing. S is for skin thinning and striae. H for hypertension and hypokalemia. I for immune deficiency and infection. And N is for neutrophilia. G is for glaucoma and other eye manifestations like cataracts. O is for osteoporosis and avascular necrosis. Another I for insomnia and other neurologic problems, and lastly, D for diabetes, and BAM, just like that, Cushingoid. The last of the immunosuppressive drugs we'll discuss here are the TNF-alpha inhibitors. There's not a whole lot you have to know about these drugs, but recognize the names. The two you'll most commonly see are adalimumab, that's Humira, and infliximab. These are monoclonal antibodies that bind to and inactivate TNF-alpha. There's a third drug with the same effects that you should know about because of its slightly different mechanism. This is etanercept. It does not end in the suffix mab because it's not a monoclonal antibody. It acts as a decoy TNF-alpha receptor, and therefore binds TNF-alpha, not allowing it to exert its pro-inflammatory effects. All of these are potent drugs used in refractory autoimmune disease, such as inflammatory bowel disease, rheumatoid arthritis, and psoriasis. And another difference with etanercept is that it's not used in IBD. Really, the highest yield point about these drugs for you to be aware of is that they must not be given to patients with latent TB. We know that TNF-alpha is responsible for maintaining granulomas, and blocking this effect can cause reactivation and dissemination of tuberculosis. All patients prescribed these drugs must be tested for TB exposure prior to receiving them, either with a PPD or a quantiferon gold assay. These drugs also predispose to infection in general and should therefore be avoided in neutropenic patients as well. One last thing to cover in this lecture, and it's not especially high yield. You should just be aware that there are drugs that can be given to stimulate the production of immune cells. The drugs in this class are filgrastim, also known as GCSF, for granulocyte colony stimulating factor. It stimulates the production of granulocytes in the bone marrow of patients who are neutropenic. There's also a drug called sargramostim, which is GM-CSF, granulocyte macrophage colony stimulating factor, which also stimulates the production of monocytes. Their use is fairly simple: leukopenia. Just be able to recognize these if you see them in a question. They will end in the suffix stim because they stimulate leukocyte production. And that's it for the immunosuppressants. Not a terribly high-yield group of drugs other than the glucocorticoids. Definitely just focus on the relatively more testable points for everything else. If you like this video, share with your classmates and friends, give it a big thumbs up, and hit the pathognomonic icon to subscribe to the channel. And we'll be coming out with more videos on other high-yield boards topics, so ring the bell if you'd like notifications. And as always, please leave your comments below and tell us what we're doing well and where we can improve. Thanks for watching, and I'll see you next time.